Welcome to EPG Pathshala. Today we are going to discuss about gases in laparoscopy. So in outline, I would like to mention that laparoscopy, although it's a technique which has come up for the past few decades, its growth has been unprecedented. It has covered each and every areas of the body and also each and every specialty of surgery. It is so common now that laparoscopic cholecystectomy is a word that every general people know about it. The central component of laparoscopy is creating a working space in the body cavity where a surgeon can work with his instruments. The gaseous insufflation of these body cavity is a central component of laparoscopic surgeries. Carbon dioxide is the most common gas that is used. The principles of insufflation and how body reacts to it is determined by the biophysical principles, and hence it is essential that laparoscopic surgeons should know about these principles, how these gases works, and also those people who are involved in the development of these laparoscopic surgeries, laparoscopic instruments, and further any advancement that comes in this field. So okay, now we are going to start by understanding the core basics of this topic and moving ahead. The topic is the role of gases in laparoscopy, and the prime role of gases is that it is able to lift up the walls of the cavity and provide a working space for the surgeon. The abdominal cavity is the most common cavity that is used in laparoscopic procedures. The effect and the product of this lifting of the abdominal wall cavity by the gases is so good that it is the gold standard against which all the other alternative devices of abdominal wall lifting cavity are compared with. It not only provides a clear field for the working, it is also safe for the electrosurgical equipments that the surgeons are using in the surgery. And as we know now that electrosurgical instruments are the part and parcel of today's surgery. And due to the recent advancement, although it is recently advanced for the past 10 to 20 years only, there has been n number of articles and n number of researches on this topic. So it is thoroughly studied, thoroughly researched, and overall gaseous insufflation of the abdominal wall cavity or any cavity for the matter is considered to be very safe. Now on the next slide we can see two diagrams. In the first leg we can see that how a trocar is entering into the abdominal cavity, especially into the pelvic cavity, and it is putting gas and insufflating the cavity. The second is a very good picture where we can see an area like pelvis where the organs are so close that the biggest problem is pelvic is to have a good working space where a surgeon could work. And here we can see that all the female reproductive organs are very well seen. The uterus, the fallopian tubes, the dome shape elevation of the cavity is one of the best exposure that a surgeon can get in an abdominal cavity in laparoscopy. Now again, if we are having gaseous insufflation of the abdominal wall or any cavity for that matter, we do have some alternatives for it, and the main alternatives that we have are abdominal wall lifting devices. This does not involve gases, so it is also known as gasless laparoscopy. The thing is, it comes in two parts. The one is intra-abdominal lifters which come into the abdomen and lift the abdominal wall. The second is subcutaneous abdominal retractors. They are used in high risk patient because the thing is, in gaseous insufflation of the abdominal cavity, it has its side effect. But if we are lifting the abdominal cavity physically, it does not affect the other organs of the body. The problem and the downside is the retraction that I said is gold standard in the gaseous insufflation. The retraction is not that good when abdominal wall retractors are used. These are like pyramid flat topped view and retraction that we get. Also when we retract the abdominal wall mechanically, all the bowel comes in between and the working space is not that good. Currently what we are using them in is in compartmental surgeries, for example like appendicectomies and cholecystectomies, where only a single compartment of the abdominal wall has to be exposed. They are not good for complex surgeries where all abdominal compartments have to be used in a single laparoscopic surgery. Another down point is that although it's called gasless laparoscopy and abdominal wall retractors are used, we still are using initial pneumoperitoneum. We are still infusing gas in the starting so that we are able to set up these abdominal wall retractors. In the next diagram we can see that there is a subcutaneous abdominal wall retractor that is lifting up the abdominal wall, and again there is a pyramid flat topped elevation and it is better seen intraoperatively. Now starting with the gases in laparoscopy, we need to know what are the ideal characteristics that we expect out of these gases. The first is it should be colorless. The second is it should be odorless. Both of these are the basics that we require because we are going to operate into that cavity, so we need a colorless and odorless gas in the operation theater. The other factor is painless. The carbon dioxide, which is the most commonly gas that we are using, is painful, but the other factors that we are using it, if these gases are painful, there are some gases with the help of which we are able to perform procedures in local anesthesia only. Also, they should be stable and inert. This factor comes because if we are going to use the gases in operation theater into the abdominal wall cavity where this could be absorbed into the blood, we expect it to be stable and inert. We do not want some chemical or biological changes into those gases. It should not also support combustion. The reason for that is because, as we said, the electrosurgical instruments are the part and parcel of today's surgery. If we cannot use this instrument, the surgery is greatly hampered. Another important factor is the solubility of the gas. The solubility of the gas decreases the incidence, or you can say the risk of gas embolism, which is a fatal complication. Also, even if gaseous embolism takes place, it is better manageable if the gas is soluble. Another fact is that it should be cheap and inexpensive. The reason for it is because if we are doing laparoscopic surgeries at that number of patients, we need to have a gas which could be easily procured, easily transported and easily used. And the last is it should have minimum cardiovascular and autonomic effects, because there are some gases which independently affects the heart muscle and vagus and release of ADH and whatnot hormones that we have to do perioperative monitoring for that patient and becomes risky in a high risk operative patient. Now, the second component and the very important component that we need to discuss is the biomechanical effect of these gases on the body. The biological effect varies from person to person, whereas the mechanical effect is same for all the gases. So, the first and foremost we are going to discuss about the mechanical aspects. Now, these are the aspects these are the effect which gases put onto the body because of their mechanical effects, because of their pressure. And discussing them in chronological order, we are going to discuss about how the rate of inflow of gas into the cavity affects it, how the temperature and the moisture of gas affects it, and the most important, how the pressure of the gas into the inflated cavity affects the body. Now, discussing the first and foremost is the rate of introduction of gas into the abdominal wall cavity. Abdominal wall I keep saying because it is the most common cavity that is used and we are currently using right now. Means the most of the surgeries are performed in abdominal cavities, in laparoscopy. So, the first is we introduce the gas into the cavity. It could be done by a closed technique, use Veress needle, which in the gas inflow rate is 2 liters per minute, or we can also use the open abdomen approach. This is used through Hassan's cannula, and the rate of gas flow through it could be up to 35 liters per minute. Our target should be that the gas inflation should be slow and comfortable, and up till when around 2.5 liters of gas is there into the abdominal cavity, so that it is full, and when we are introducing other trocars and cannulas into the abdominal wall, it provides a counter pressure against it and hence saves the organ. The second part is temperature and moisture of gas that we use for inflating this cavity. Although it has been proven in multiple studies that a humidified and a warm gas around 32 degrees centigrade would be the best for the patient, still currently the gas that we are using most commonly is a dry carbon dioxide gas. The problem with that gas is that when a dry room temperature cold gas enters the abdominal cavity, it irritates the peritoneum. And also in experimental studies, it has been shown in rat models or so that it creates post-operative adhesions. We hope that this is something that would be established and would be coming in surgery soon. Okay, next we have a diagram where we can see the panel of an insufflator. This is a panel which is continuously kept in front of the surgeon's eyes, where he can see the pressure, the inflow rate and the total amount of gas that has been put into the abdominal cavity up till now. So, these are the monitors which are present there, and surgeon continuously monitors these variables. Now, we are coming to the most important part, that is the pressure of the gas into the cavity. Now, starting with the first, that is the cardiovascular effects that our body faces after when the gas is put into the cavity. The first one is the stretching of peritoneum. As soon as the gas enters the abdomen cavity, there is sudden unnatural stretching of the peritoneum, and this results into a vagal reflex. And due to the vagal reflex, there is sudden bradycardia. Although later is going into tachycardia, but there is sudden bradycardia. And this bradycardia is the most common arrhythmia of a laparoscopic surgery. Also, due to this pressure, there is compression of other organs, vessels in the abdominal cavity. One of them is the vena cava compression. It has two results. The first is that the preload going towards the heart is significantly reduced. The second is the blood coming from the legs up to the heart, that is also significantly reduced. So there is a blood pooling in the legs and the risk of deep venous thrombosis is increased. Another part is due to the effect of the gases itself and also due to the mechanical pressure, there is rise in mean arterial pressure and systemic vascular resistance. With decreased preload and increased mean arterial pressure and independent effects of the carbon dioxide, we have increased cardiac workload and pressure on the heart. The second system that is affected is the renal system. The renal parenchyma and renal vein, to be very specific, are compressed by the pressure, very little the renal arteries. So what it results is that there is activation of the renin, angiotensin, aldosterone system, and this is also due to the indirect effect of the gases and all over the body, and there is increased ADH secretion. So the body starts to retain water, and we see that in the perioperative period after few hours when the ADH level falls and the patient puts that water through the urine out of his body. So the net result is during the laparoscopic procedures there is decreased glomerular filtration rate and also decreased urine output. The other effect is on the respiratory system. This pressure on the gas affects the diaphragm and the diaphragm is not able to move. So this is called diaphragmatic splinting. So during that time there is increased peak inspiratory pressure. We have to use, the anesthetist, to be very specific, has to use increased pressure for the ventilation to go on. The second part is, which would be dealt in the carbon dioxide part, is that although there is associated hypercarbia, to flush out the carbon dioxide, the anesthetist has to use higher ventilatory rates so that the carbon dioxide could be pushed out of the body. But that rate cannot be put about over 20, because if we are putting the respiratory rate about 20, the gaseous exchange, proper gaseous exchange does not take place. So at that time this could cause a problem in laparoscopic surgeries where the surgery has to be halted, the pneumoperitoneum has to be deflated, and the time has to be given to the body so that the body is able to flush out the carbon dioxide. So these are some of the respiratory effects. Now here is again discussing about the systems or organs. An endocrine system is a system where the effects are somewhat contrary to what was expected. What was expected was in open surgeries the body would be facing a more stress and hence higher level of cortisols would be released, but that was found to be contraindicatory because in laparoscopic surgeries higher amount of cortisol was released. But the good part is very soon after the laparoscopic surgery ends, the level falls off and it comes out as a result that laparoscopic surgeries in the net result gives better endocrine system response than open surgeries. Below there is a diagram, which a schematic diagram which shows how the pressure effects and gas specific effects are there of gases in laparoscopy. The pressure effects are peritoneal distension, vagal reaction, elevated diaphragm, splinting of diaphragm, altered venous return and pain. The gas specific effects, for example taking carbon dioxide in example, are related to hypercarbia, acidosis, increased afterloads, increased catecholamines and stress on the heart, that is myocardial stress. Now this is a very big slide because we are going to discuss the biological effects of each and every gas. Starting with the carbon dioxide, which is the most common gas. It has good factors like it's odorless, colorless and stable. The good part of this gas is that it's cheap, easily available in the environment and we are easily able to procure it. Another good part is that it allows all electrosurgical instruments because it does not support combustion. Also it is highly soluble. So this decreases the risk of gaseous embolism. This is the good part. But the cons are that it causes hypercarbia. The carbon dioxide is a very good soluble gas, so it's get soluble into the blood and the hypercarbia results. And to deal with that hypercarbia, the body has to put out carbon dioxide through the respiratory system. The ventilatory rates are elevated so that carbon dioxide could be pushed off the system. But this is not usually required because the body has lot of buffers. And one of the most important buffers for this is the bone, which can absorb up to 120 liters of carbon dioxide. But yes, if the surgeries are prolonged, laparoscopic surgeries, this might become a point of concern where the buffers are all saturated and we need to alter the ventilatory results, respiratory rates, and as I discussed before, only if it goes, the ventilatory respiratory rate goes above 20, there is a problem and gaseous exchange and surgery might need to be halted. So that is the problem if surgery is continuous for very long. Also, carbon dioxide has its own independent from mechanical, independent biological effects on autonomic nervous system and on heart. It acts as a direct myocardial suppressant. So in high risk patients, in very old patients, in those cases, using carbon dioxide for gaseous laparoscopy becomes a risky business, and as we saw, we are using alternative methods like gasless laparoscopy with the help of abdominal wall retractors, specifically in those patients. Talking about another gas, we need to talk about nitrous oxide. Now, nitrous oxide is a colorless, odorless, stable gas. Also, it is soluble in blood, so it takes care of the embolism problem. It has minimal acid-base balance derangement, which is the main problem with carbon dioxide. The good and a special point about nitrous oxide is that it causes minimal pain. So much so, there are studies and there are centers where we are doing minor surgical procedures with the gas insufflation of nitrous oxide and using local anesthetic only. The downside is it has somewhat risky business with electrosurgical equipments because it supports combustion. So it gets a direct indication that it is used for minor surgical procedures under local anesthesia, but definitely it cannot be used for complex procedures where yes, electrosurgical equipments have to be used. Now we are going to discuss about the inert gases, and the inert gases comes are helium and argon. Now as we know, inert gases are inert, they are odorless, colorless, and they don't react. So they are very good in that part. Also, if they don't react, they cause minimal acid-base derangement, and they are also safe with electrocautery. Now starting with helium, helium has been found in experimental models to act as tumor suppressant. Now that's a very good thing, but then again these are only in studies and they need to be proved and go into randomized controlled trials. Also, they have poor solubility. Of all the inert gases, helium and argon both have poor solubility. So that creates a problem in the case of gas embolism, because even if a small amount of gas enters the vein, it can cause havoc and gas embolism can be fatal. And then there is another problem of subcutaneous emphysema. For other gases, if they enter the tissue planes, we don't do anything. We close the patient and in post-operative time these gases gets absorbed, but not with these inert gases. They don't get absorbed, so the subcutaneous emphysema that is created many a times during laparoscopic surgeries persist. Now another gas, argon, it has the same properties like helium that I discussed just now. That's colorless, odorless, stable, inert, and minimal acid-base derangement, and completely safe with electrosurgical equipments. Another part that has been seen is that it causes cardiac depression, but then again it has been a component of studies now. It has been there only in animal models, so their use needs to be studied more. Now discussing last is room air. It needs to be discussed because that was the first gas that was ever used in laparoscopic surgeries. Initially, sphygmomanometers, the BP machines, were used to inflate gas in the abdominal wall cavity. The properties of room gas are mainly due to nitrogen, because 70% of the gas is nitrogen. So it's colorless, odorless, and stable. As we all know, it's around us. Minimal acid-base derangement, because most of the gases are not soluble and again safe with electrocautery. But then again, the non-soluble gases have a problem that they can have a risk of gas embolism. So that is the problem with same. Also, it is painful, not as painful as carbon dioxide, but yes, more painful than nitrogen oxide. Room air is not currently used in laparoscopic surgeries. So summarizing all of this, in summary, I would like to state that the use of gaseous insufflation to insufflate a body cavity is a central component of nearly all the minimally invasive surgeries that are being performed today. It functions to provide an adequate exposure and a working space for a surgeon and his instruments. Out of all the gases, carbon dioxide is the most common gas that is used because it's cheap, effective, allows electrosurgical instruments to take place. It has its specific problems, but it has been thoroughly studied and it is kept in mind during the perioperative management of these patients and in management of high risk patients. Now, out of all the biomechanical factors that we have discussed, The pressure of the gas into the in the abdominal cavity, or any cavity for that matter, is the most important parameter. It is the most important parameter for the effectiveness of gas in providing a working space, and the most important parameter in causing its complications. At present, we do have alternatives for carbon dioxide laparoscopic insufflation in forms of other gases, and also in the form of gasless laparoscopy, where we are using abdominal wall retractors. Hope you have understood the core concepts of this topic, and hope you have liked it. Thank you.